thank you to the Lung Health Foundation for this kind invitation to be with you all today. When we first planned this event a while back now, I thought, maybe there wouldn't be that much to say. We were beginning to have a reprieve from the extreme Omicron surge that we lived through over the holidays and the early part of the winter of 2022. But unfortunately, we have quite a bit of information to go through today. And so if you'll bear with me, I will share my screen. And so, yes, again, thank you to Lung Health Foundation, and LUNGevity is pleased to be part of this as well. I do also just want to acknowledge, I know there was another loss in our lung cancer community yesterday, and so our thoughts go out to all those who knew and loved Bonnie. And so, and we send our encouragement to Gina Hollenbeck, who, many of us know and think highly of. So the community sends you love. But today we're going to be talking about finding our new normal, learning to live with COVID-19. So we have quite a bit of information to go through today. And we'll be starting with an overview of the current statistics, both worldwide, Canada, and US. I'll then briefly talk about Omicron and the current subvariants that we're dealing with. I want to remind everybody about the risk to patients with lung cancer and the ongoing risk to our community. We'll touch on masking, testing, some of the latest updates when it comes to vaccines, other treatments that are not vaccines, travel considerations, and what the future may look like. So let's start with the current statistics. So I pulled this data from the New York Times COVID tracker, and this was as of May 16th, 2022. And the World Health Organization recently reported that overall global cases of COVID-19 are decreasing everywhere except in the Americas and Africa. So if you look there at the graph on the left, you can see kind of the successive waves that we've gone through, and that large spike on the right is the Omicron surge that we lived through over the holidays into the early part of 2022. You can now see that decline, but currently worldwide, we're at just over 6 million deaths. I do want to point out that we just reached a grim milestone here in the US with 1 million deaths. And I think that's important because although the US only accounts for 4% of the global population, we account for 16% of the COVID deaths, and that is a pretty grim statistic. But then on the right, we break it out by region, and you can see that the red line indicates the US and Canada, whereas all the other curves are basically on decline. Unfortunately, we're once again seeing an uptick in cases here in the US and Canada. So given that we're with our friends from Canada today, let's look at the current situation there. So on the left, again, is new reported cases. We can see that things seem to be on the decline there. Again, we know that this isn't the complete picture because a lot more people are using rapid tests these days. So all these numbers are with the caveat of potential underreporting. But if you look at hotspots then on the right, you can see that as you get more orange or more red, that's where you have increased burden of circulating virus. And kind of consistent with what we're seeing in the US, the easternmost provinces seem to be where you have the highest burden right now. And that mirrors what we're seeing in the northeast part of the US, where there's quite a surge of activity right now. So if we look at the US, we can see those kind of successive waves that we lived through. So that middle kind of hump was the winter surge of 2020. Then we had the Delta surge over the summer last year, 2021, and then that dramatic spike that was the Omicron surge. We enjoyed a reprieve, right after Omicron, but you can see that curve is beginning a slow ascent once again. So people have said, well, cases don't matter anymore. What about hospitalizations? Well, if you look at the numbers below the graph, you can see that cases are increasing up about 60%, hospitalizations are increasing, and even ICU admissions are increasing. If we look at the graph or the map rather on the right, again, this is an indication of hotspots in the US. And you can see that the Northeast and the upper Midwest are once again turning deeper shades of orange and even red, indicating higher activity. And I'm in the Bay Area here in California, which has been held up as a poster child really of good pandemic precautions and following the science and the data. And we're currently the hotspot for California. So there are multiple reasons for that, and we can explore that momentarily. But I also want to just look at the maps that the CDC has put out there, because I know they're causing some confusion for many, including myself. If we look at the map on the left, some people kind of cynically call this the fields of green map. I call it the red light map. What this map is intended to indicate is the relative burden on hospitals. And so if the area is green, that means that hospitals currently are managing okay. They're not overburdened with COVID patients. Whereas this map has been predominantly green recently, we can now begin to see increasing areas where it's yellow and even red, particularly in the Northeast region. And this means that once again, hospitals are beginning to see patients with COVID-19. Now, the concern with this map is that when people see that it's green, they think the pandemic is over, we're good to go, we can resume life as normal. That is with the caveat, then if we look at the map on the right, this is our community transmission map by county. You can see that once again, the United States is frankly on fire with virus. Where we see orange and red, that means there's substantial to high amounts of circulating virus. And the levels we currently see are comparable to what we saw during the Delta surge last summer. So there's not an insignificant amount of virus out there. And I think anecdotally, probably all of you know that to be true, because I personally am hearing more and more cases of friends and acquaintances who have recently been diagnosed, and there's a lot more cases in the news. And we will begin to sort out why that's happening. But again, there's a lot of virus out there right now. And so, as I mentioned just a moment ago, unfortunately, we hit a grim milestone here in the US on Monday, I think officially, but flags have been flying at half staff through May 16th to commemorate this moment. So 1 million deaths in 2.5 years, which is unprecedented. We really have to go back in time 100 years to see a pandemic that has been this deadly for the world and for the US. And this infographic kind of shows you how we got to that path of 1 million lives lost. Here, the pink bands represent the different waves of virus that we've lived through. So if you look at the bottom lower left corner, that's March 2020 when the pandemic first erupted. We can see that deaths continue to increase. The circles indicate the number of deaths kind of occurring. So you saw, again, if we go kind of up halfway, January 2021, there were a lot of deaths during that winter surge of 2020 into 2021. Then the next pink band to the right, September 2021, we were living through the Delta surge. And then, of course, as we all know, our holidays and early part of 2022 were dramatically impacted by the OMICRON surge. And so, yes, unfortunately, we've reached 1 million deaths in just 2.5 years. So let's take a moment and talk about Omicron and its current subvariants or cousins and what we're seeing there. So here I present a couple of infographics. And what we see is that the different cousins of Omicron, if you will, are given different colors. So here, Omicron, the original parent strain that caused the dramatic spike over the holidays and early part of this year, is color-coded deep purple. So if you look at the bottom of that graph, you can see the date. So February into March, Omicron, dark purple, was the predominant strain that was circulating here in the US. Over time, we've seen in pink, a subvariant, BA2, become the predominant variant that we've been dealing with. And now you can see in kind of that red color, the increasing presence of yet another subvariant called BA2.12.1. And this variant is actually, I pulled this data that's current through May 7th. I think it's up to 47% now. So it's actually expected to overtake even BA2 here in the US. But that's not the full picture if we look globally. So beyond the original parental strain of Omicron, which was BA.1, we have BA.2, and then in South Africa, they're starting to see an uptick in cases caused by subvariants BA.4 and BA.5. Now, why is that important? I can tell you that historically, South Africa has served as a bellwether for what we can perhaps expect to see in Europe, here in the US. So, the jury is still out on how prevalent these additional subvariants will become, but I think it's important to know that they exist. And another source of concern is that whereas we have relied on surveillance efforts in places like South Africa to alert us to the presence of new variants of concern, some of that activity is being shuttered, as well as vaccine production facilities in Africa because of lack of uptake there. And so our ability to anticipate and be proactive about newly emerging variants is compromised as those activities are reduced. So it's important that we have these global surveillance efforts to be able to be as proactive as possible going forward and prevent, to the extent possible, massive waves of new variants. So what does the relative infectiousness of these subvariants look like? Here on the left, I show a cartoon. This was pulled from Dr. Eric Topol, who's one of the thought leaders that I follow on Twitter. And it's showing that if you go back to the original strain that emerged in March 2020, that was the alpha strain. Then we had, obviously, Delta, which came online last summer. It was more infectious than the original alpha strain. And then, of course, if we go up in terms of infectiousness, Omicron was highly infectious. We talked about it was very transmissible. And yet here we are with two offshoots of Omicron, BA.2 and BA.2.12.1, that are even yet more infectious than Omicron. And there are some different key features of these variants that I want to highlight for you. So if we look in this table here at the top, we see the increase in transmissibility. So BA.1 is the original parental Omicron strain, so it's called reference here. BA.2 was approximately 30% more infectious than Omicron. BA.2.12.1, which again is about 47% of circulating cases right now here in the US, is about 25% more transmissible than that. And then, of course, if you look at BA.4 and .4, BA.5, there's some increased transmissibility over BA.2. What do these variants look like in terms of immune escape? Now, people said that if you were infected with Omicron, you had some protection against potential reinfection, and that held fairly true for BA.2, but it seems less true for BA.2, .12.1, and BA.4 and BA.5, meaning you can't rely on having been previously infected with the parental alpha or delta or Omicron strains. You are still susceptible to reinfection with these newly emerging variants. In terms of ability to infect cells, the newest versions, 2.12.1, is even more infectious than earlier strains. So we keep going up in terms of infectivity. I'm not going to go into the key mutations. That's beyond the scope of this discussion today. But in terms of cross immunity, again, I was talking about, you may have had some protection if you were infected with Omicron against infection with BA.2. That seems to be less true in terms of these newer subvariants. Resistance to monoclonal antibodies. You may have heard some discussion about this when Omicron hit. We had some monoclonal antibodies in the medicine cabinet, if you will, but we discovered that many of them didn't work against Omicron. And in fact, the FDA suspended use of some of the monoclonal antibodies in the midst of the Omicron surge because they just simply didn't work. And so while that continues to be true for BA.2, it's even more so for these newest emerging variants. Places where dominant their parental Omicron strain, BA.1, has now been outcompeted by these subvariants, by its cousins, if you will. So BA.2 is, over 100 countries. It's pretty much global at this point. We're seeing, again, this rapid kind of increase in the presence of BA.2.12.1 here in the US, whereas in Africa, they're beginning to see the increased presence of other subvariants, including BA.4 and BA.5. Now, what does it mean in terms of vaccine effectiveness? So we obviously know the science is abundantly clear at this point that 3 shots are better than 2 shots. So in terms of vaccine effectiveness against hospitalization, and again, I want to reinforce that these vaccines, especially the mRNA vaccines, are extraordinarily effective at preventing severe disease leading to hospitalization and death. They have more than delivered on what the original goal was. But if we look at effectiveness against Omicron, which is BA.1, it was reduced compared to the parental strain, where we got, maybe 94, 95% protection against the original strain. That dropped to about 81% with Omicron. It's pretty consistent with BA.2, and the jury is still out. These new variants are still so new that we don't know how well the vaccines perform against them. That being said, again, if we look at the bottom row, the effectiveness of only 2 doses against hospitalization, you can see that in the face of Omicron, that number dropped significantly, only 32% protection against hospitalization. With BA.2, maybe slightly better, but the takeaway here is if you have not gotten a 3rd dose yet, you should absolutely get that 3rd dose of vaccine. Even though it's against the original parental strain and not Omicron specific, you're still going to get benefit from that booster dose. So I want to remind our community, because we're here on behalf of the lung cancer community, but thinking about overall lung health, what's the risk for patients with lung cancer? So our community needs to continue to be vigilant. The early data coming out in 2020, conducted by groups like with the TerraVault study and others, showed high mortality in patients with lung cancer, anywhere from 30 to 40 some odd percent, sometimes higher in some studies. So again, that was before vaccines were here, but our community is very vulnerable. What is absolutely crystal clear now is that vaccines are safe and effective for patients with cancer. I know there were concerns that patients with cancer weren't necessarily highly represented or included in the early clinical trials, but that data is now, there's no arguing with it that vaccines are safe and effective for patients with cancer. I'm part of a study being led by Drs. Fred Hirsch and Adolfo Garcia Sastre at Mount Sinai Hospital in New York, that's funded by the National Cancer Institute, that's looking at the immune response in patients with lung cancer to SARS-CoV-2 infection and vaccination. And what we're finding thus far is that the majority of patients with solid tumors, including lung cancer, mount a strong antibody response. Our data is showing that there's a small fraction, maybe 5%, who don't. And so it's important for us to continue to study to figure out why that's the case. We can't point to any clear reasons why yet, and it may eventually lead to more tailored vaccination protocols for patients with lung cancer. But the good news is that majority of patients with solid tumors mount a strong antibody response. That's contrasted with patients, for example, who may have blood cancers where they don't mount necessarily as strong of a response and remain much more at risk. Even then, even if you have had your vaccines and your boosters, the risk of breakthrough infection remains, especially with these newest variants. So, that should not be minimized, and breakthrough infections can be serious. So my, advice to you is to make sure you're current on your vaccines and boosters. Get that 2nd booster. If you qualify, timing wise, go ahead and get that 4th dose or that 2nd booster. I know there was patients who were immunocompromised were allowed to get a booster maybe before it came online for the general public. So just make sure you're current with the guidelines that are recommended. So again, this was some data that was published earlier this year, and it's just showing you again that even among patients who are fully vaccinated who have cancer, there are risks associated with breakthrough infections. So 65% of them required hospitalization, 19% were admitted to the ICU, and unfortunately, a small fraction, 13%, died within 30 days. So again, I just want our community to know that they need to remain vigilant, and the reality is now it's kind of up to you to continue to take those precautions to protect yourself and your loved ones if you're, the family of somebody with cancer or lung cancer. So masking, it's clear that masks work best when everyone wears them, point blank, full stop. I mean, masking is an essential piece in our, efforts to minimize the pandemic and to get it behind us. Unfortunately, now we've seen suspension of mask mandates in most places, and they're no longer required on public transportation in most places. So many of you wonder, well, since masks aren't required, do I get any benefit if I'm still masking, but everybody around me is not? So let's look at that scenario here in the table. If we look at the top of this panel, it's, let's say you're a person who's uninfected and you're wearing a mask, and it shows the different options going from nothing to cloth mask to surgical mask to N95. On the left, on the vertical axis, is a person who's infected in what they're wearing. So if that infected person is not wearing anything, you do get benefits from masking, but it's reduced. So if you're wearing only a surgical mask, you're going to be protected for maybe 30 minutes. So the point here is wear the best mask you can get, preferably an N95 or a KN95. Make sure it fits well, there are no gaps, and you'll get some protection and benefit from that mask. Obviously, the best case scenario is if everybody is wearing a mask, preferably an N95, and that's what we see at the bottom lower right corner, where you get about 25 hours of protection. My other piece of advice is there are a lot of masks that are out there on the market, manufactured in different places, and the quality can sometimes not be maybe what you think it is. So if you have any concerns about the quality of your mask, there is a resource that they've taken the guesswork out of it. They've done the homework. They've sourced properly. They've sourced good masks for you. So you can go to Project N95. They have lots of different options available for purchase, and I encourage you to check that out. But here we are also going into a major cancer conference here in a few short days. And so there are calls both from patients and from the oncologist community that ASCO leadership enforces masking at their conference. And so I would lend my voice to those requests and hope that ASCO leadership does require masking for all attendees to protect not only the community attending the conference, but the community they serve back home when they return to their respective locations. Testing, let's go over that quickly. So I just want to remind people of some of the differences between PCR and rapid tests. So both can detect active infections, whereas antibody tests detect prior exposure. PCR historically has been the gold standard that detects the genetic material, in this case, RNA of the virus, whereas rapid antigen tests detect protein from the virus. During Omicron, there were issues with access, availability, and turnaround time. I think a lot of that has improved. Obviously, I think rapid tests, for example, are much more readily available. But because we saw a reprieve from Omicron, a lot of testing facilities, I think, scaled back, some maybe even closed. So in terms of PCR tests, there may be issues for different reasons now than back during Omicron. But I think we've also seen greater uptake in the use of rapid tests. So when should you test? We think about surveillance versus symptomatic. Surveillance is the idea that you're kind of regularly testing, even if you're not experiencing symptoms. So there are various good reasons to do that. Certainly I have children who are school age, and we did that more consistently, I will admit, during Omicron. And we do that occasionally now still, but certainly if you're symptomatic, you want to test ASAP. You want to stay home if you're symptomatic and get that test done. Which test is best? Honestly, I don't have a recommendation at this point. I have seen the rapid test perform consistently, so I think we have much more confidence in them than maybe we felt during the Omicron, where people felt they needed PCR. I won't make a recommendation about brand. I have experience with a number of them at this point, including Binax, including iHealth and others. The FDA has authorized the tests that are available. So, I think there's confidence in those. Just this week, it was announced that you can get 8 more free tests per household here in the US by going to the website shown. So I encourage you to do that and keep them on hand, because they are another layer of protection that we have in the face of this ongoing pandemic. And here in the US, again, insurance must cover 8 tests per family member per month in the US. I will admit I haven't taken advantage of this service yet, so I haven't navigated the process of getting reimbursed, but that is also available to you. So this is a curve that tries to explain the difference in sensitivity between PCR and rapid tests. If we look at the vertical axis on the left where it says viral load, that's the amount of virus in your body, whereas across the bottom, it's days since exposure. So you can see this red curve that kind of spikes and then falls off over time. The benefits for PCR and why it was considered a gold standard were that it is actually able to pick up the virus maybe in that early stage before you're actually fully infectious. Now, the downside is you can see there's that long tail of the virus kind of declining, and PCR can continue to detect the genetic material, the RNA, from the virus for periods beyond which you are considered infectious. Now, that became an issue when we were talking about reducing the time that you quarantine when we went from 10 days to 5 days and thinking about testing out of quarantine. Obviously, people can test positive by PCR for sometimes weeks. And so that's why we discouraged maybe using it for that context. But the rapid test more consistently kind of detect you within that infectious period. So that's, some of the difference between the two tests. I do want to back up because I have a friend, in fact, a scientist who was just recently diagnosed herself. And, the unusual circumstance she found for herself is that she continued to test positive by rapid test for 25 days. Now, I just want to put that out there because as people are, thinking about resuming travel and other activities, you need to figure out what it will mean for you if you go somewhere and you have to test negative to get on a plane to return home. You may be stuck. So it's just better to go in with your eyes open and have information so you can plan accordingly than to be caught off guard. So I think that was an unusual circumstance, but it's one that occurred. So it's better that you be aware. When do you test? Obviously, if you're symptomatic, stay home, test. If you're participating in a risky situation, a crowd event, a conference, I would say test before you participate. If it's a conference, test during that. Don't go interact with people. Test in the morning, maybe. And if you come up positive, then obviously you're going to need to isolate. And then certainly test after you come back home. If you're gathering with high-risk individuals, again, we're talking about our lung cancer community who remain at risk, test before you go see those people. Don't risk exposing our vulnerable community to virus. And the CDC issued new guidance this week that they encourage everyone here in the US to test within 3 days of domestic travel, even if you're vaccinated and boosted. And that's an important piece here because remember, I told you we're dealing with much more highly transmissible infectious variants. And so breakthrough infections can and do happen. And there's a website you can go to called whentotest.org that breaks it out for individuals or for organizations. And you can put in different information about number of contacts you have kind of on a regular basis, how many people you interacted with over the previous week versus, kind of planned interactions. And it is an algorithm that helps you kind of figure out if you need to test. I say when in doubt, test, just make it part of your regular activities that you do. Boosters. How did the boosters perform against Omicron? So this is looking at 2 doses or 3 doses of mRNA vaccine against Delta or Omicron and the effectiveness against ER or urgent care visits. Here, the blue line indicates protection with the Delta variant, and the red line indicates the Omicron variant. So you can see that the first 2 data points on the left are for if you were less than 6 months after your second dose. Obviously, you had much better protection against ER urgent care visits with Delta compared to Omicron. If you were more than 6 months beyond that second dose, that protection declined even more and was much more reduced for Omicron. But the good news was that after getting that booster, you saw restoration of protection for both variants. And, yet still, you were only about 82% for Omicron. So there was some reduction in protection in the face of Omicron compared to Delta variant. This looks at the same comparison only against hospitalization. And you can see again on the left, that was if you were more current, so less than 6 months out from your second dose, versus the middle where you were more than 6 months out versus after a third dose. So if you were 6 months or more out, you were definitely reduced or impacted and had a greater risk of being hospitalized. But that booster helps bring that protection back up against hospitalization, even for Omicron. So again, we know that Omicron is trickier and the subvariants are trickier, but the vaccines continue to perform well against hospitalization and death. Now, the vaccines were never intended to block infection. They were intended to prevent the worst outcomes of infection, which would be severe disease leading to hospitalization and death. And they've more than accomplished that. The icing on the cake, if you will, was that they did, in fact, actually lower risk of infection. And even during the Omicron surge, we saw that the vaccines continued to provide protection against infection. So if you looked at adults who were unvaccinated, they had a 5 times higher risk of infection compared to adults who were fully vaccinated with a booster. So there was that added benefit of, they're going to keep you out of the hospital, but they may also protect you against infection. So again, my take-home soapbox message to you is be current on your vaccines and boosters. So should I get a fourth dose? Here in the US, it's recommended for adults over age 40, or rather over age 50, or kids who are 12 and up who are immunocompromised. Now, it's important to understand that your antibodies will be boosted, but that may not be enough still to prevent breakthrough infection. That's based on data that came out of Israel, but you're still going to get that protection against severe disease, hospitalization, and death. I think it's worth reinforcing and stressing that we are not going to boost our way out of this pandemic. It's just not the solution that's going to end this for anybody, unfortunately. And so in that regard, there are efforts underway to develop variant-specific boosters. We all heard talk about Omicron-specific boosters. Now that strain is no longer really prevalent, it may need to be tweaked for some of these other subvariants. But, there are also next-generation vaccines that are being developed that will be kind of strain agnostic. So we think about pan coronavirus. It would either cover all the coronaviruses because, SARS-CoV-2 is actually number 7 of the circulating coronaviruses, or it might be, address some of these specific variants. And then alternatively, there are several efforts underway to develop intranasal vaccines that could hopefully block infection or transmission. So more to come on that front. There are some updates that are relevant in terms of vaccine news. So I know all of us are eagerly waiting for vaccines to come online for our youngest individuals, our children under age 5. And so Moderna has applied for FDA authorization. Pfizer is doing additional tests. It looks like they may need 3 doses instead of 2 doses with their version of the vaccine. So I've seen some speculation that maybe by next month we'll have some movement on this front. So fingers crossed, because we need to get our children protected, our youngest children protected. Just yesterday, the FDA authorized the Pfizer booster for kids age 5-11 if they're at least 5 months out from their second dose. Recently, the FDA severely limited the J&J vaccine due to a rare clotting disorder. This was kind of a 1 in a million thing initially when you may recall that the J&J vaccine was halted for a brief period before and then came back online. Well, now we've kind of, we talk about it as a vaccine of last resort for somebody who is unable or maybe unwilling to take an mRNA vaccine, but it shouldn't be the first option that's offered to individuals. Again, current vaccines are very effective at preventing severe disease, hospitalization, death. Next generation vaccines will either try to target all variants or try to block infection and transmission. A lot of that is going to depend on, we had the benefit for the original development of vaccines with Operation Warp Speed and a large influx of money to make that happen. And unfortunately, current federal funding is about to dry up for COVID efforts. And so in the absence of that, it's going to make it a lot more challenging to deliver some of these new options, or even continue to develop tests and make those available and all the different drugs that we have. So we're hopeful that funding will be sustained. Other treatments. So there are some non-vaccine treatments that we have that are being used. And so one is for high-risk individuals to as prophylaxis to try to prevent infection. This is Evusheld, which is a combination injection. And so that is being used to some extent. As I talked about earlier, we had various monoclonal antibodies in the arsenal that are used following infection, but many of those were discontinued since they were found not to be effective against Omicron. And so, we need continued research to develop more monoclonal antibodies to round out, our available supply. You've probably also heard lots of discussion about antivirals such as PAXLOVID, the Merck drug molnupiravir, that's a mouthful, and remdesivir. Both PAXLOVID and Merck's drug are oral drugs, which is obviously much better than having to go in and have an injection or infusion. These are designed to lower your viral load, decrease symptoms, but again, must be administered soon after infection. So again, that's where that testing piece is so important. So you want to catch your infection as early as possible. So if you're high risk, you can start these drugs as soon as possible. PAXLOVID, a couple of things to point out, and we'll talk about it more in just a moment, but it interacts with a lot of drugs. So, I think even if you aren't currently infected, you should have a plan in place and talk to your doctor to know if your various medications that you're on will interact with it. There was some discussion earlier this week. I was talking back and forth with Janet Freeman Daly, like, do we know which tyrosine kinase inhibitors, for example, interact with PAXLOVID? So just know there are a lot of things that interact with it, and it's better to know that in advance so you can make a plan for if you'll have to discontinue some of your medications, especially if you're a patient with cancer, what it will mean for your cancer treatment as well. With Merck's drug, the M1, I'll just say that, it's not recommended for pregnant women. So that one is off the table if you are pregnant or thinking about becoming pregnant. There's been a lot of kind of buzz about PAXLOVID rebound cases recently. Stephen Colbert was a high-profile case where normally this is a 5-day course of treatment. There's typically quick resolution of symptoms, but there are now increasing reports of people finish the medication and then within a few days they test positive again. We don't know how prevalent this is yet. I think it warrants obviously further study. There's some key unanswered questions about that. Does it mean those people are infectious again? Do they need to isolate and quarantine again? Do they take the drug longer? FDA has pushed back on that, where Pfizer says, yes, maybe. Pfizer's like, there's no evidence for that. And then Pfizer also did a study. I'd draw parallels to maybe prophylactic use of Tamiflu when flu, is circulating in a household. They wanted to find out if the person, say I had COVID, should my husband and children take PAXLOVID to hopefully prevent them getting infected? The answer is it doesn't work for that purpose. So PAXLOVID doesn't prevent household infections, so it can't be used in that way. Travel considerations. Sorry, I know I'm throwing a lot of information. I'll try to get through it so we can answer your questions. There's a great risk assessment tool that Georgia Tech developed. You can select your event size. It pulls the current data and it can tell you and help you plan, like, if it makes sense for you to go to an event. So just for fun, I did, it's spring, so we're in the midst of graduation and wedding season, all those exciting activities. If we look at the graph on the left, that's for an event size 500 people. And it shows you the relative risk that at least one person in attendance will have COVID. So you can see there's a lot of red there, meaning there's a greater than 99% chance that somebody in the crowd is going to have COVID. Let's say we're going to a conference and there's at least 1,000 people there. You can see that red gets even more prevalent, especially in the Northeast and upper Midwest. So, COVID may be wearing a name badge to your conference and it's going to be an unwelcome guest. So you need to be adding in the precautions that we have available, which is masking and testing and hand washing and all the things to stay safe while you're participating in those activities. How can you lower your risk if you're traveling? And some of these things apply even if you're not traveling. Obviously, being current on your vaccinations and boosters applies for everybody. Wearing a properly fitting mask, the best mask you can get your hands on, applies to everybody. If you are traveling, you can turn up your fan at the seat on your plane. And I want to say I pulled this from Dr. Angela Rasmussen off Twitter, who's a virologist and a well-regarded COVID thought leader. But you can turn up the circulation at your seat. If you're thinking about dining, how crowded is it? Is there good ventilation? Are there outdoor options? Right now, while we're in the midst of a surge here in the US, try to pick outdoor options when available, or are there open windows and good circulation of air. Prioritize those outdoor activities and exercise. So maybe avoid the indoor gym. Testing. Everybody should be doing it regularly. Keep tests on hand. Take with you if you're traveling. Avoid hugs. I know I'm a hugger, but it's worth it. Wash your hands often, sanitize them. If you're traveling, what does your insurance cover? Do you need supplemental medical insurance, for example? Will your credit card cover extra expenses for medical emergencies? If you go somewhere and you suddenly test positive and have to quarantine for an extra period of time, will your credit card cover the hotel charge? Can you get PAXLOVID? Talk to your doctor and have a plan in place. Take extra meds. We're talking to our, a cancer community here. Take extra meds if you get stuck somewhere because you tested positive. How will your treatment be impacted if you get stuck somewhere? These are all the kinds of things we need to think about. What does the future hold? So, as long as there's virus circulating, there's risk of a new variant. And that's the unfortunate reality of how viruses work. And those inputs can come from multiple places and potentially all of them in parallel. We know that because people who are immunocompromised may not amount to an effective immune response against the virus, we may see emergence of new variants there. And there was this discussion that maybe some of the variants have emerged in patients who were in South Africa who were immunocompromised, so it can happen. Animal reservoirs, we don't know the original source of this virus. It seems that it may have been in bats or in the animal markets, but we know that the virus is circulating widely among white-tailed deer here in the US. So as we continue as humans to encroach on animal populations, that risk of mixing and exposure is present. We talk about global containment and issues of equity and access and getting vaccines everywhere in the world. As long as there's virus, everyone is at risk. Until we're all safe, none of us is safe. Co-infections or combinations between different variants, that's still on the table too. So all this means that we're not out of the woods. Will it ever end? Cases and hospitalizations are up everywhere in the US. Some research predicted here, what does endemic look like? We think it could mean 100,000 deaths in the US, even once it's endemic. Are we endemic yet? I would say that's debatable. I'm not sure that I agree with Dr. Fauci on that point just yet. We need continued funding for infrastructure, testing, drugs, new vaccines. Unfortunately, this may be our new normal for the foreseeable future, and there's always the risk of long COVID, which we still don't fully understand. Where's the silver lining? It sounds like I'm trying to scare you to death, and I hope you don't take it that way. Knowledge is power. We have very effective vaccines. We know much more about how to treat COVID-19 now than early 2020. We have highly effective non-pharmaceutical interventions, including masking, social distancing, hand washing, and ventilation. The signs are pointing toward this moving away from pandemic to an endemic situation. We have the ability to make informed choices based on our individual risk profile and tolerance. What can you do? Plan ahead. If you're traveling, think about your access to antivirals, have a plan in place, talk to your doctor before you get sick, not after you get sick. Keep rapid tests on hand. Continue masking indoors, on public transportation, at crowded events. Prioritize ventilation. Pick outdoor activities, especially where there's a lot of virus. Make smart choices based on not just your risk profile, but that of the people in your immediate household. If you live with aging parents or young children, you've got to take into account all those considerations. Use the risk assessment calculators and when to test tools that I shared with you. And with that, I know that was a lot of information and I appreciate your patience. I will open the floor for questions.
Thank you so much, Dr. Moore. We've had some questions come up in the Q&A, a lot around flying and the masks. So one person asks, if you're wearing an N95 or a KN95 on the plane and other people are not wearing masks, are you really protected for the 2.5 hours, or does that complicate the issue?
I mean, certainly you're going to get some protection, right? And I would say I would avoid, to the extent possible, taking my mask off, for drinking or eating, or I would do it very quickly, because we used to think about the 15-minute rule in terms of, length of exposure. And that was, kind of over a 24-hour period. Since these variants are so much more transmissible, that 15-minute is not 15 minutes anymore. We may not know exactly what it is, but it's a lot less than 15 minutes. There have been some parallels made to maybe as infectious as measles. I'm not sure if we're fully there yet, but measles is the most contagious virus that we have. So don't want to scare you. I would, take those precautions that we talked about, turn up your air, but the air circulation on planes makes it safer than maybe we think. And so you are going to get benefit. Just wear that mask. I would say you could even double mask, so you could wear your N95, you could put a surgical mask over that. Obviously you're thinking about, what if my flight's longer than you said 2.5 hours? What if I'm going to Europe or somewhere international, or even across the US? I'm in Canada and it takes a long time, or I'm in California rather. It takes a long time to get across the US to see people. Double up, and make sure that if you're going for a good reason.
Yeah. Let's see. So someone says, I don't know how to plan ahead regarding antivirals. If I'm in the middle of the country while driving from New York, for example, to California, I'll be between doctors and I'm not sure how to get a hold of the antivirals. I guess that's specific to the States. Any suggestions on availability?
I think, in that case, it's a valid question, right? I think I would still have the advice of talk through this scenario with your primary, care doctor and say, I'm planning this trip, and what happens if I test positive, midway through. There are some what are called test to treat centers here in the US, where I think it was really intended for people who may not have, insurance or access to healthcare, where they could go and get access to testing and treatment all kind of in one place. So that might be an option. And I think even when you look at some pharmacies, some of them are designated like test to treat location. So that's why I'm saying, like, I certainly don't have all the answers, because there's a lot to kind of keep track of, but talk to your primary care doctor, do some homework and see kind of on that route, where would you go? What would it look like? And
time, right. Someone asked, what about outside transmission? Should lung cancer patients wear a mask outside if they can't stay 6 feet apart from others? Eating outdoors, how close or how far? Under a tent with flaps with about 100 people, should you always wear a mask even when you're outside?
I think, given it's a fine line, I don't want to unnecessarily set off alarms, because I think that the good thing is that it seems that most patients with lung cancer look like they do mount a pretty healthy response to vaccination. But yes, I just have a mask on my person pretty much, at all times. And I still mask if I'm going to the grocery store. I still mask if I'm going to be, kind of in a crowded situation. To me, it's not an imposition. It's something I do not only for myself, but for others. So I would say just take the mask with you, put it on, it's easy enough to do. And certainly if you're going to be in close quarters, even outside, if it's crowded. I'd rather be safe than sorry.
Yeah, no, that's right. You make a good point. Someone was asking that they'll be traveling to Vienna for the lung cancer conference. How are the trends in Europe, and where's the best place to find current information?
So the New York Times tracker, where I pulled those maps at the beginning from, is a good place. They have just relaxed, I think, more restrictions and are dropping mask mandates on planes as well in Europe based on what they said were declining rates. If you look at the hotspot map internationally, Europe is still lining up pretty dark. It obviously the landscape can change between now and August because these things rapidly evolve. And so we've got, these new variants circulating in South Africa and so I can tell you that it's still common enough that it goes into my own personal calculation about whether or not I'm going to World Lung. And it's not just because of COVID. I mean, there's also a war, unfortunately, but I think it needs to be a strong consideration for people. And as I said, if you're obviously in the US or Canada and you're going to travel to Europe, you've got to think about what will happen if you get over there and you test positive and, you have to test negative, obviously, to be able to get back on the plane to return home. So you just need to make sure you are planned for all the possibilities and what that will look like in terms of securing additional lodging and getting treatment and all that.
All right, thank you. And then someone asked about the study done that found that 65% of fully vaccinated cancer patients contract COVID are hospitalized. Was this earlier in the pandemic, or are those recent statistics?
That publication was from earlier this year, and that was even with some data from OMICRON. So, we don't have more updated information, but what I'm hoping to impart, because it continues to be true, is that even if that was in fact earlier variants of the virus, what we're dealing with now is much more contagious and transmissible than that. Now, some people will say, but yet it doesn't seem, none of the variants that we're currently dealing with seem to result in more severe disease. That's true, but that I think it bears, consideration, because even in people with lung cancer, and I know several kind of personal examples of people with lung cancer who got infected with Omicron, who did land in the hospital, and it was, not trivial. Thankfully, none of them died, but it just is trying to reinforce the point that we don't want to just rip the Band-Aid off and resume life as normal, that we need to still continue using precautions.
Thank you. And then someone wants to know, are you able to identify the variant that you're infected with? So if you've been diagnosed with COVID, is there a way to know?
Yeah, unfortunately, the tests that we have aren't really designed for that purpose. And the way that we know kind of the frequency of what variants are circulating is that the CDC, for example, does surveillance. So, they will take samples to various places in the country, and they will sequence that virus to get a sense as to of the number of viruses that we've sequenced from, this region or that region. This is the kind of breakdown of which variants are most common. So you're just going to know that you are positive that you have COVID. And then based on, during the height of Omicron, it suddenly became that it outcompeted Delta, and, it was accounting for the majority of the infections. So we said if you were infected in January or February, March, you could be fairly certain that you had Omicron, but you're not going to know on an individual basis which variant you have.
Okay. And there are lots of questions about the boosters while testing positive for COVID. Should you wait until the symptoms, until you test negative to get the booster, or can you get the booster while infected?
What I think the advice is to wait until your symptoms resolve. Obviously, you don't want to go in to get a booster while you're infected and potentially expose others. So, wait until, and there had been changing kind of recommendations, if it was 30 days, or at one point they were saying like you could wait up to 90 days, following infection to get a booster because you're going to get some kind of bump. But I think the current recommendation, and I would need to confirm this because again, things change, the guidance is you need to wait at least until your symptoms resolve.
Okay. I see questions about long COVID. Any treatments in the pipeline for long COVID? Any new discoveries around long COVID and how to address it?
I think the good news is there's a lot of funding that's being put forward here in the US to study long COVID. It's such a still mysterious, thing that we're dealing with because SARS-CoV-2 can affect so many different cells and tissues in the body. That means it has wide-ranging impacts. So we know that it can have impacts on the nervous system, on your brain, that there can be brain fog and neurologic symptoms that, are long lasting. There are impacts on the heart. So even a year post-infection, we can see that people are at increased risk for heart attack and stroke. There's impacts on the kidneys. So people may develop diabetes after. The list continues. I've heard cases of thyroiditis or, basically any organ that can be infected, you can have issues. So I don't know that we have a uniform treatment. I think we're still learning. I think it's becoming hopefully more in the minds of doctors that this is something we need to look into. But yeah, we have a long way to go on understanding long COVID, how to treat it. And I think it may depend on what particular manifestation you're dealing with, what complication, if you will.
All right.